Thanks, Murray, and thanks for the invitation back. It's good to get out of Washington, even though it's actually warmer right now in D.C. than it is here. But I want to begin by giving a shout out to Bill. I couldn't agree more with his talk. I have a lot of respect and admiration for Bill. We've been on different sides of the aisle, so to speak. We started our career together working on food stamps, but I do think the situation in Washington is not good in terms of the deficits. And if you look at that italics line, if you take anything away from my speech, that is my main message, if you will. And the tax bill is kind of the first symptom of that. I think I got the honor of going first because I predicted that the ACA would survive. Some of my panelists did not last year. But it was a little tight, let me say. I mean, there really was an extensive grassroots efforts. And as a result of that, I think right now, and one of the speakers in the first panel mentioned that, both Medicaid and ACA now have stronger public support than going into 2017. I think a lot of it also had to do with the CBO analysis, that every time there was a new Republican repeal and replace bill, where they outlined the impact of that. I think that had an enormous help. The California stakeholders, and I was in touch with them regularly through this process, worked very hard. And they also helped Arizona when the debate moved to the Senate. And initially, I thought we had the repeal effort stopped in the House, and then they brought it back, as you know. And despite the fact that California has probably implemented the ACA better than any other state, it's taken down the uninsured rate enormously. All 14 House Republicans voted no. And if we had just had 3 or 4 or 5 of them, it would have failed in the House. So, and I remember Kevin McCarthy, who is the number 2 Republican in the House, when he gave his statement of why we had to repeal the ACA, he didn't talk about California, because he couldn't talk about California and how well it was doing. He talked about my home state of Iowa, because Iowa was having a little difficulty. And I think the Republican governors, also Kasich, Baker, and others were very helpful in the process. And, you know, it failed in the Senate primarily because of 3, Murkowski, McCain, and Collins. So it was very close when it failed in the Senate at about 1 a.m. in the morning. I think the ACA will continue to prevail, and while we've had a lot of executive branch sabotage, the marketplaces will still have substantial enrollment. And if you look at the state-based marketplaces, they actually increased enrollment in the last year a bit, while the federally facilitated markets declined. I think the ACA has had other successes in terms of slowing spending growth. Part of that is because we ratcheted down the subsidies to Medicare Advantage plans. We did other things, and so you can see Medicare over the period from 2010 to 2016 in terms of per enrollee spending is actually negative. Now, a lot of that is also due to the fact that 65-year-olds are joining the program and the 85, 90-year-olds are exiting the program, the more costly ones. So it's not, again, I'm not saying that's all because of the ACA. California is the ACA success story. We've had very low premium increases in this state. We've taken the unemployment rate down enormously. There's many carriers here, et cetera. And I think we need to duplicate that in other states. In terms of the short-term agenda, I think the bipartisan budget agreement is one step forward, and that's because we eliminated the defense and non-defense sequesters. Bill has already talked about that. We also got the disaster assistance to Texas, Florida, Puerto Rico, Virgin Islands, and the California wildfires. We've got, but all of that together, this budget agreement increases the deficit probably by $1.5 trillion, assuming we have a similar agreement for 20 to 21. I mean, you've increased defense and non-defense enormously, and if we don't have another agreement, there's going to be sharp cliffs. So the chances of extending this agreement are going to be very high. And if you look then at the 10-year impact of that going out, it is huge. In terms of, I also predicted we would get most of these extenders. It took me a little longer than normal to get that done. It didn't get done by September 30th as it should have been, but we did get 10 years of CHIP done. We repealed IPAB, and then now we got $18 billion in pharma offsets. I want to talk about one of them. Unlike the other years, I've been involved in negotiations on the SGR bill and the 2015 budget agreement. And every time we went into those negotiations, my Republican staff counterparts would say, you're not touching pharma. You can touch hospitals, you can touch a lot of other providers, you're not touching pharma. This year, that was different. And we closed the donut hole 1 year sooner. Now, what we really did was we demanded that pharma's contribution in the donut hole went from 50% to 70%, actually 75%. The last day of negotiations in the Senate, they moved it back from 75 to 70. Pharma is very agitated. It gave me 1 day of joy to learn how upset they were that they didn't actually know about this until it got unveiled when the language was printed. CBO thinks we hit pharma by about 12 billion for that. Pharma thinks we hit them for 20 to 45 billion. So I don't think that there's some agitation about these pharma offsets, so we'll see. So here are some of the other things we got done in the agreement. I'm particularly proud of Families First. That's in the child welfare area. And that created an open-ended entitlement for child welfare preventive services. I would say the opioid epidemic, if there's one thing we're going to get done this year, that is it. Funding to do something about this. I mean, to me, it's amazing. We've had 63,000 deaths from opioids in 2016. That's as many as we lost U.S. casualties in the Vietnam War. It's 1 year. Life expectancy in this country has actually declined, mainly because of those deaths. And the overdose death rate rose 21% in 2016, 19.8 persons per every 100,000 of us. The overdose rates are the highest in West Virginia, Ohio, New Hampshire, DC, and Pennsylvania. California actually has one of the lowest. I'll go to the next slide here. And you can see these are ordered alphabetically. West Virginia is way over there, a little over 52 deaths per 100,000. California, as you can see, is right there, it's lower. But every state and region is being affected by this epidemic. What'd I do? So we have called, the leader has, my boss has been, went to a subcommittee which leaders normally don't do, and testified about the urgency of this. We need to expand access to medication-assisted treatment. We need to expand the number of substance abuse treatment providers. We need to expand opioid research in NIH, et cetera. Now, I'm under no illusion that by spending a little more money, we're going to turn this epidemic around. I think it's going to take a lot more effort. We're going to be at this for some time. The other thing that's going on is the GPO sabotage of coverage. We got the individual mandate repeal in the tax bill. We've had cuts to outreach and marketing. They've stopped the cost sharing reduction payments last September, October. They've issued a regulation on association health plans yesterday or the day before. They shortened the open enrollment. They shortened open enrollment, but they also put out the reg on short-term limited duration plans. The Obama administration had said these are only good for 3 months, and those plans do not have to follow the essential health benefits. They can discriminate against people with pre-existing conditions and the like. They have now expanded that to 12 months. My understanding that between the individual mandate repeal and the short term, we are probably going to increase premiums for 2019 in the individual market, the non-group market, by 15 to 20%. And now, again, if you're in the market, one of the things about the ACA, if you're actually less than 400% of poverty, you tend to be completely protected from that increase. But if you're outside, above 400% or otherwise ineligible for benefits in the exchange, you are going to feel a very big increase again in the individual market. They've also are talking about, well, we now have 2 states, Kentucky and Indiana, that have instituted work requirements. They're talking about lifetime limits in the Medicaid program. And there's also talk about another reg dealing with public charge. So that all is having a huge impact. What happened last year when the cost sharing reductions were eliminated, and California kind of led the way here, Peter Lee, Diana Dooley, and others, we basically loaded the cost of the CSRs onto the premium subsidies for those in the exchange. And CBO is estimating that way of doing it, it made the gold plans less expensive relative to the silver plans. And I think if that continues, you'll see more take-up of the gold plans. It's kind of the Democrats' dream to make the gold plans relatively less expensive, but it's a very expensive way of doing it. Now, Speaker Ryan has indicated that he wants to wait till we see the CBO revised baseline. I don't think it's going to be 194 billion. It could be in the 125 to 150. And then if we do a direct appropriation of the CSR, we will get those savings, and theoretically we could put those into reinsurance. So we could offset that 15 to 20% increase in premiums that I just talked about if we did some federal policy. Now, I am somewhat pessimistic that we're going to get that done, mainly because they are saying Hyde language has to be attached to these cost-sharing reductions, since it's now a direct appropriation. So I'm very pessimistic that we're actually going to get this done, but it would be a benefit. I mean, the other things we would like to do is we'd like to rescind some of these executive regulations. We'd like to spend more money on marketing and outreach. We'd like to remove the 400% cap, et cetera. Now, what we're arguing, Democrats are saying to the state of California and other blue and purple states, the states, can overcome all of this. You can do things here in your California Assembly, your California legislature. You could restore the individual mandate, just like Massachusetts did. You could improve affordability by getting a 1332 waiver. You can completely stop the short duration by state insurance regulations, et cetera. So my point is that I do think, and I think Bill said that as well, that some of the locus now of activities on health policy is going to move to the states, mainly because outside of opioids and maybe something else, we're not going to get much done in Washington, D.C. We've talked about, I think there is some bipartisan support to reduce drug spending. Pay for delay creates, which they argued hard against. Creates is basically requiring a brand company to give a sample to a potential generic under REMS. And CBO is saying that would save another $3 billion. We could encourage the use of more generics. Democrats' favorite line here is negotiation. Now, I've explained it, the economist in me has explained that many times. You're not going to have anyone willing to negotiate unless the winner gets something. And it's very hard to steer 50 million Medicare beneficiaries to the winner of the bid. It's just not going to happen. And that's why CBO has said there's no savings from drug negotiation. Now, I think where there could be savings from negotiation is where we have a specialized drug that's just gone on the market that has a monopoly, and the government could say, give us your best price. You could have various negotiating techniques. And in return, the government would then say to all public beneficiaries, you are entitled, you have now access to that drug. So there would be something in it for pharma to negotiate, because then anybody that's clinically could use that drug would get access to it. For example, Gilead, who makes Sovaldi, et cetera, the Texas Medicaid program doesn't even talk to them. So you have a lot of people who have Hep C that aren't getting advantage of those drugs who are public beneficiaries. Pay for value, inflation rebates, or some other things. So the one step forward on my opening slide was the budget agreement. The two steps backward are the GOP tax bill and the 2019 president's budget. I may need to update the first line here. I said voters currently reject the Republican tax bill by a large percentage. I'm not convinced that's going to continue, mainly because corporations, CEOs are putting a lot of money explaining the benefits of the tax cut. There is a lot of sugar in that bill in the first couple years. It's going to explode the debt by $2 to $2.5 trillion, and the tax cuts are primarily focused on higher income Americans, as I'm going to show you in a moment. The implications of it, besides borrowing money from China to help wealthy individuals, it's going to result, and I'm not as confident as Jim Glassman is about our ability in Washington right now to do something about Medicare, Medicaid, and Social Security. And by that, I mean restore those programs to solvency by both raising taxes and tweaking benefits. I do not see it because of our very partisan nature right now. And I do worry a little bit more that at a time of very low unemployment, large deficit spending that we're talking about going out into the future, running deficits of well over $1 trillion, could result in inflation, could result in that bond rate, interest rates going up, with even more implications for the federal budget. So here is, this comes from the Tax Policy Center. These are not my numbers. I want you to focus on two things. If you look at, in 2018, the third line, the third quintile, that their average reduction as a percent of after-tax income is 1.6%. The top 1% is advantaged by 3.4. So a lot of the benefits are going to the top. Now look at those same two numbers in 2027, when a lot of the tax breaks have expired for individuals. The middle class gets 0. And the top still gets a reduction in their after-tax income of 1%. Now, what I worry about, think about this for a moment. The budget that just came out, we have revenues as a percent of GDP below 17% of GDP when the baby boom is retiring. That's well below our average, which I think is about 17.8 over the last 40 years. And if anything, revenue right now should be a percentage point above our average, not below the average. So this is going to have large down the road implications, but in the very short run, it probably will increase growth a bit in 2018 and 2019. But the pain of it all is going to come down the road, and I hope the American voter is smart enough to realize the implications of all of that. There's a little showing what's happening here, just emphasizing what Bill has already told you. And I'll say a little bit about the president's budget. I mean, again, he repeals and replaces ACA with Graham-Cassidy. There is no chance of that happening this year. My guess is that we will not even have budget resolutions in either the House or the Senate. I may be wrong about that. But there's a lot of pain in it for Republicans because they're going to have to admit they're not balancing the budget. And there's no need to do that from an appropriation standpoint. Why do you need a budget resolution? Two reasons. One is to give the appropriators their top line number, which the 2-year agreement has already done, although there's a big caveat to that, and the administration is already backing off of those agreements. The other reason to do a budget resolution is so you can do reconciliation instructions and pass legislation in the Senate with just 51 votes. Again, I don't see that happening this year because I think with the election of Doug Jones, et cetera, they realize that they're not going to do another run at Graham-Cassidy. And I don't think there's anything else that they really want to use a reconciliation instruction for. I won't go through, again, Graham-Cassidy eliminates the Medicaid expansion. It cuts food stamps by $214 billion, et cetera. I borrowed this a little bit from the Washington Post, but I mean, if you look at his proposals, he's touching third rails that Trump said he would never touch. He's scaling back support for the forgotten person that he talked a lot about in his campaign. He's giving up on a balanced budget, relying on very fuzzy math. A 3% growth rate for the next 10 years is not going to happen. And then there's an $813 billion growth dividend in addition to those optimistic economic assumptions. So all in all, a big step backwards. This is a paper done by the Center on Budget, Paul Vanderwater. And the point of this slide, and I would say Paul used pretty conservative assumptions here about what's going to happen to Social Security, Medicare, and Medicaid, and the discretionary programs. The point is, given our demographics in this country, spending is going to increase 2 to 2.5%. And that is why revenue needs are going to have to go up, not down. And we are not preparing ourselves for the retirement of the baby boom. I'm going to say a little bit more about that. The other thing I want to say about universal coverage, improving upon the ACA is clearly the most cost-effective way or budget-effective way of getting to universal coverage. Single payer is very expensive. The Urban Institute says $30 trillion. It creates winners and losers. I mean, you're taking basically everybody that's getting employer-provided benefits and putting them onto the federal budget. Now, again, in that process, you're going to create winners and losers. Some of the retail stores that don't offer very good benefits are going to be benefited. Some others that get very wonderful coverage through their employers are at risk of losing some of that. And so the point here is I do not understand why all the excitement in California is kind of ground zero for some of that excitement about universal coverage. The leader is very aware of the cost of that. It has no chance of happening in the next several years, et cetera. And I would say, the Medicare for all, Medicare right now doesn't have an out-of-pocket limit. It would not be eligible for going on to the exchange. So where I think the debate has to go is improving Medicare and Medicaid. Democrats don't have a very good answer right now, in my opinion, to block granting Medicaid. I think we've got to be thinking about taking some of the long-term care cost off of Medicaid and putting it onto Medicare or financing it directly. We've got to talk about slowing healthcare cost growth, and we need to build the case for revenues to make Medicare and Social Security solvent and to finance long-term care. And I'm not saying there shouldn't be some benefit tweaks in that, but I think most of the burden needs to fall on the revenue side, not the outlay side. There, it's keeping promises. Basically, it's demographics that are going to drive this debate. So in conclusion, I think it's time to move from our acute debate, which is basically focused on 6 or 7% of people in the individual market, to long-term care and what we do about that. The tax cuts simply cannot survive given our country's demographics. We need to improve and strengthen the ACA, and that can happen at the state level. And my main point, we need to prepare for the retirement of the baby boom generation. Thank you.